So cardiacs are doing heart stuff for the next foreseeable future. We're going to be talking today about ACS, acute coronary syndromes. That's where you lack blood supply to your heart. So you have little coronary vessels that come off the aorta right there, right past the aortic valve. You have some coronary vessels, so we're going to learn about those, the right coronary, the left main, LAD, circumflex, all those vessels, and what happens when they get occluded, what happens when they get blocked, right? And first section, we'll talk about the symptoms and the diagnostic tests and complications and interventions as far as cath lab goes. And then we'll talk about the 12 lead, right? The 12 lead EKG findings. So again, this course builds on basic dysrhythmias. So we'll talk more about dysrhythmias on our next lecture, but we will talk about, ST changes, EKG changes, T waves, QRSs, Q waves, all that fun stuff. Okay. So we're talking about the lack of perfusion to the heart as our primary goal today. All right, so acute coronary syndrome. All right, it happens because you have CAD. So you have coronary artery disease. The disease usually most commonly is from a buildup of atheromas and atherosclerosis, plaque inside the vessels, right? And that plaque is very brittle, I guess you could say. It's made of collagen fibers and calcium and all kinds of LDLs, right? They've got LDLs in there too. Okay, so in nursing school and like before ICU, we were worried about diet, exercise, quit smoking, all those things, which is still important. But now we're in ICU and we're trying to deal with the problem. The problem has already happened. They can't quit smoking. Oh, I guess they could quit smoking because they're not going to smoke in the ICU. But you could tell them, afterwards, as far as the teaching plan is all what you learned in nursing school, right? Or as as an outpatient kind of perspective, a tele perspective, for instance, on discharge. But we're worried about this little atheroma that ruptured, and it ruptured and exposed its collagen, right? Which is very naughty. Expose your collagen, that makes platelets attract, right? So platelets will attract right away to that, and it's going to block off and form a what? What do those platelets form? They form a clot, and that will then, yes, occlude the heart, right? So we give these patients, after their intervention and also before the intervention, we give them aspirin, right, to stop the platelets from aggregating or clotting, right? We also give them anticoagulants. So we'll touch base on a few of those guys, such as, so we got aspirin right there, and we have P2Y12 inhibitors, right? So P2Y12 is a receptor site on the platelets that we want to inhibit. Okay, so we're going to get discharged on aspirin and DAPT, aspirin and P2Y12 inhibitors, which is called DAPT, D-A-P-T. DAPT is dual antiplatelet therapy, right? We don't want this thrombus to happen in the future, right? It happened now, cool, but now we want to stop it from the future. So we got to make sure they're on this post-cath lab, right? Post-intervention, for instance. All right, and we also have other things we want to stop. We give statins to stop the formation of LDLs, reduce their LDLs. We give beta blockers. That's going to stop the remodeling of the heart. We give all kinds of other fun stuff as well, which we'll touch on. Okay, so we got CAD, and then ASCVD leads to CAD. So we want to stop that in its tracks. And we've got acute coronary syndrome. So acute coronary syndrome is when you are basically being admitted to you come to the ER and you're being admitted to the hospital. So there's a little umbrella term for ACS, right? So you have a few different things. You have unstable angina, you have NSTEMI and STEMIs. And STEMIs are probably going to be going away. I mean, a STEMI is a STEMI. It's an ST elevation MI, right? But there's all kinds of STEMI equivalents. And there's all kinds of things that it used to be just, oh, there's a new left bundle branch block, and now there's, oh, they have Wellens waves, oh, they have Scarbosa's criteria, oh, they have De Winter's T waves, and now, so there's like 10 different equivalents to a STEMI now. So they just kind of renamed it as an OMI, a obstructive MI. All right, which is what's happening. We've obstructed complete flow to the coronaries, and now we have, an occlusive MI is what they call it. It is obstructive, right? So OMIs are the new STEMIs, basically. OMIs lead to STEMIs, but they also lead to all these other 12 lead EKG findings that we'll touch base on today. Okay, and we'll touch base on 12 leads, right? We're not getting into the weeds with 12 leads. You'll feel like, well, these are the weeds. These aren't the weeds. But we are going to talk about the ST changes and T wave changes and Q wave changes that happen with CAD, ACS, and such, right? Because 12 lead is a rabbit hole you can really go down. You can talk about left bundle branch, right bundle branch, left fascicular block, anterior fascicular blocks. You can talk about all axis deviation, all these other things in 12 leads. But we're focusing more on the coronary artery disease perspective. Okay, so people used to pay money to look at big people, right? There's a 24-year-old. Look how big that person is. It's 1890 World's Fair, right? People paid money. They walked around the corner there, oh, and then they left the exit and they lost their 25 cents, right? So that was a huge thing, right? The bigger people, obese people were not popular. Were only found in royalty, right? Like King Henry VIII was big, and then also, you know, these people here who they probably had a genetic disorder where they had a cholesterol forming disorder or something to that effect. But either way, that was a rarity, and now it's much more popular nowadays, right? You don't have to, you have to pay money to see a bigger person nowadays. All right, so the overview of ACS and ASCVD. So we're touching base kind of ASCVD. That's what's kind of leading to coronary artery disease. That's what's causing, nine times out of 10, that's usually the reason why they came to the hospital is because they had underlying ASCVD. And there are certain factors that make them more at risk. But what is ASCVD? It's the new cool term for atherosclerosis, right? They don't say atherosclerosis anymore. They say atherosclerotic cardiovascular disease, right? ASCVD right here. Okay, so what's going on there? You're forming atheromas. You're forming that blockage, just building up, building up, building up until it pops, right? And it's unpredictable when it'll pop. It'll just pop at any point. And that's why if they're at high risk, they should be on aspirin at home, and they should be on other medications and diet, exercise, stopping smoking, stopping alcohol. All these things can prevent the formation of atheromas, right? But in the meantime, when it pops, that is when you're going to get our acute coronary syndrome, right? So when you have this blockage here, or they have high risk, basically the umbrella term, they have CAD. They can have what's called stable angina, where they're walking, and they get chest pain, right? That's called stable, and then they stop walking, and the chest pain goes away. That's called stable angina, right? I have angina, which is chest pain on exertion, right? Chest pain on exertion is stable angina. If that chest pain doesn't go away, that's considered unstable angina. Or if it just happens all of a sudden, right? They got their feet kicked up in the lazy boy, they're watching the Olympics, right? They're watching Simone Biles, and then all of a sudden, they get a coronary intervention, they get a coronary blockage, and that's going to cause might cause ST changes, and might not. So we have to go to the hospital because my chest pain is not going away. Usually if they were, being seen a doctor and they know they're high risk, they'll probably have some nitrates at home, they'll have probably some nitroglycerin, right? So they know the instructions to how to take it, hopefully, or they just keep taking like 6 doses and like, oh, it's not going away, I guess I'll call now. And then we have to, look at them in the hospital, figure out what's going on. Do they have troponins that are leaking, right? Are they troponin positive? Do they have ST changes? If they have ST elevation, it's a STEMI. If they don't have ST elevation, it's a non-STEMI, right? A non-ST elevation MI, right? So they have unstable angina is under here. So you got UA is under here. You got STEMI and NSTEMI. Those are the 3 different possibilities. Someone comes with chest pain at rest or chest pain that doesn't go away, right? If that chest pain goes away, it's called stable angina, and yeah, they can be discharged with some nitrates. There's like ranolazine, which can be prescribed, right? It's down here somewhere, but that's a medication that, yeah, they could try to avoid it. We're going to start on beta blockers, start on other things to kind of prevent the progression of their disease process. Okay, one of the things that do that are preventing the formation of these lipids and foam cells and this inflammatory process, right? Yes, they can lose weight, stop smoking, etc., but we want them to, you can give them, we know that doesn't work, right? We tell them, okay, lose some weight, and they come back and they haven't lost weight. So it's like, well, let me give you a medication, right? So the medication being our statins, right? So statins are usually our go-to agents to prevent this LDL buildup, right? Post-MI, people are going to be on it because they found out that statins are actually prevent inflammatory processes inside the coronaries. So it's actually better to give them within 24 hours of their MI, not just on discharge, right? So you want to get those guys in there to prevent the formation of LDLs, which is kind of our whole problem here. Our LDLs are depositing here along with calcium and collagen, and again, when platelets see that, what do? That's it's time for dinner, right? They're going to get activated, and they're going to then form a clot. Okay, you start getting calcification in there as well, and you start getting symptoms of chest pain when you got about 40% blockage. That's usually when they start getting the symptoms of maybe stable angina, or it could just pop, and then all of a sudden they get a MI. Okay, so CAD, basically you have chest pain, and it's either it goes away or it doesn't go away, right? So what else? It's atheroma ruptures, and we want to stop it by giving a, of course, aspirin. We'll give some statins that maybe later, not the priority. We'll give beta blockers. We'll give things to prevent this MI from progressing. And of course, we got to figure out on EKG, do we have some changes or not? Okay. And statins are, as far as like a scale of 1 to 10, statins are like a 10 at efficacy. And then if someone can't tolerate statins, then we switch them over to these other agents that are like bile sequestrants and cholestyramine, ezetimibe, all these other agents, and those are like a 5. So you go from like a 10, it's like super effective reducing LDLs and cholesterol, then you go all the way down to 5. So the best medication, if they can tolerate it, is statins, right? What are some side effects of statins though? You want to avoid them with liver enzymes elevated. It causes transaminitis, causes elevation of your liver enzymes, and your liver function doesn't work. You get coagulopathic, or you get other, you can damage your liver, and other medications can build up. It can be a problem. Also, a hard sell is that it can rupture your tendons. I mean, no notice, just your tendons can rupture, right?
This is the loud sound a tendon makes when it snaps. This person caught an Achilles tendon rupture on video, so listen closely. There it is. Follow for part 2 and I'll...
All right, so an ASCVD event is what we're trying to avoid, obviously, with medications like statins and such, but these guys are going to be something that we want to, we want to see worst case scenario. You could have an MI or a stroke or a peripheral arterial disease occlusion. So this thrombus doesn't only just include our coronaries. It can include many different things. It can include our, MIs, cause a stroke, cause peripheral arterial disease. It can cause all kinds of problems. These are called atherosclerotic events, right? So these ASCVD events, we can, hopefully we can catch on before it even happens by changing someone's diet, starting on statins, etc., reducing LDLs. Hypertension puts extra stress on your heart, extra stress on your arteries, and then that's going to then lead to inflammation. And inflammation basically is what's causing the atheroma to kind of take hold. Right? Tobacco smoking we can stop. Diabetes we can hopefully get under control. It causes hypertension in and of itself, but also it causes what's called hyaline arteriosclerosis. It's a glass-like formation, like when you get crystallization of your glucose, right? Your hemoglobin A1C. Everything else is crystallized also. So your nerves are crystallized, you get neuropathies, your vessels are crystallized, you get hypertension, but also it's a perfect place for the cholesterol to take hold. Right? And of course, obesity is an inflammatory state in and of itself, and that's going to, all these things together are going to put some more risk for an ASCVD event, which happens because they were building up atheromas over time, right? And then, yeah, so once they can kind of recognize this if they're in the hospital setting, they follow up with their doctors, but ultimately they come to the ICU or they come to the hospital because they developed a MI of some sort, or they developed an embolic stroke, right? An MI because the atheroma ruptured. Okay, peripheral arterial disease, they have angina, their arteries can get occluded, right? They even get a AAA or a thoracic aortic aneurysm rupture, right? Where the actual artery ruptures over time. And another risk factor is death. Another ASCVD event is they end up just dead because of one of these events above, right? So it attacks every organ. So heart, brain, the renals, our periphery, and then just vascular-wise, just causes hypertension. Right? Hypertension puts more stress on the heart, like we mentioned, and that can lead to an aneurysm, that can lead to a stroke. Extra blood flow to the brain is going to pop a vessel, and you're going to start bleeding inside the brain, right? And that puts you at risk for CHF. And CHF is basically what happens after an atherosclerotic event, right? So you have an MI, you can then A, get recovered, you might have good recovery, or B, you die, or C, you have long-standing CHF from that. Or it can be progressive. CHF can happen when you have like long-standing hypertension, but extra stress on the heart, right? And CHF itself puts you at risk for an MI. So it's all a downward spiral once we start getting all these things interacting. Okay, so again, the heart causes coronary artery disease. You might start with stable angina, but you will eventually lead to acute coronary syndrome, which is your unstable angina, NSTEMI or STEMI. And then now we have an MI in our hands, because usually STEMI definitely are MI. Sometimes unstable angina is a big warning sign. Just like a TIA is a big warning sign that, oh, I got to change. Next 30 days, you have like a 70% chance of having a stroke. So, it's kind of almost like a TIA. You let them know that they have to change their ways, right? And then that can lead to CHF. And then we have, the brain can be involved. We get stroke happens from hypertension, and also, hemorrhagic stroke happens from hypertension, but also ischemic stroke happens from hypertension because you're damaging the vessels in the brain. That's a perfect milieu for our atherosclerosis to take hold, and now that starts occluding. This vessel is any vessel in the body, right? So we get a thrombotic stroke that can happen. We get an embolic stroke if it's the carotids that start getting blocked over time. Once you start getting more than 70% blockage, it needs intervention. If they don't, that can embolize to the brain, right? And then, of course, you get cognitive impairment. Alzheimer's disease and such is because of ASCVD. And then renal stenosis, or kidneys start getting involved. They don't get the blood flow they need. They can start developing chronic kidney disease and lead to failure of the kidneys, or end-stage renal disease. And that leads to hypertension, right? And now we're back to almost square one, right? And then also you don't get rid of inflammatory mediators when you have end-stage renal disease. So that all builds up and puts you at more risk for inflammation and more risk for ASCVD to develop. And then the periphery, we'll kind of touch base on this with, I think, hematology. It kind of makes sense in hematology. We talk about peripheral arterial disease. That's anywhere but the heart or but the brain. That's peripheral arterial disease. Usually it's going to be the extremities, right? Because they're not getting flow to the toes. They start walking, and they get angina of the toes. But it's not called angina of the toes or angina of the leg. What's it called? Intermittent claudication, right? That doesn't make sense. All right, so they got pain in the legs on walking, and it resolves with the rest. That sounds like angina, right? That is a sign of peripheral arterial disease, and it's a sign that if you have vessels in your legs that have problems, probably your heart has problems too, right? And also, it's not, I don't think I put it up here exactly, but also erectile dysfunction, right? People don't always go to the ER for erectile dysfunction, but if the vessel size of the penis is about the same as the heart, all right? So when they have erectile dysfunction, they probably are high risk for coronary artery disease, okay? So there's all kinds of risk factor modification we can do, but again, our focus is to look over here on EKG changes, troponin changes, and symptoms, right? Is this person in front of me having an MI or not? Okay. So is it an MI or is it something else? Because when someone has chest pain, it's actually not the most common cause, is not an MI. There's many different reasons why someone has chest pain. Same thing with EKG changes, right? When they have EKG changes here and have ST elevation, an MI is not number 1 on the list, like number 8, right? So there's all kinds of other reasons why you might have ST elevation and other reasons you might have chest pain. But we got to figure out what is the worst, what is the, not the worst case scenario, because the worst case scenario is an aneurysm that's ruptured, an aortic aneurysm, right? But we have to figure out, is it chest pain? Do I need to wake up a cardiologist at 2 in the morning, right? To let them know, hey, I got EKG changes, we did a troponin, that's positive, and he has these symptoms. And by the way, these are the same symptoms he had when he had an MI last year. So whoa, that's a quick, tip. It's like when someone has chest pain, have you had this chest pain before? Yeah, when I had an MI the last 3 times. It's like, well, this might be an MI again, right? But how do you know someone has angina, right? Has chest pain? We know stable angina is it goes away with what? With rest, or chest pain happens on exertion. And then of course there's unstable angina, which is the chest pain just right there. And then they don't always have EKGs. Even your Apple Watches don't tell you have ST elevation. It'll tell you if you have AFib and if you're tachycardic, but it won't tell you have ST elevation, right? So you have to go to the emergency room to get that assessed to see if we have ST elevation or ST depression. And we have to figure out what's going on. Is this, because some patients don't always have the classic presentation of chest pain, right? Classic presentation is where it radiates from the heart, right? And it goes up to the jaw or it goes down to the arm. Actually, both arms is more common than just the left arm, okay? And why does that happen? Well, if my muscle is dying, it's spilling all its contents, or before it dies, it's going to start going to anaerobic respiration, right? We're going to start producing lactate. And lactate builds up, it's going to then, other inflammatory things build up, it's going to then be ejected from the heart, right? And that's going to eject up this way, because that's the first 3 branches of your aorta, right? And why is it the left arm more than the right arm? Because it's a straight shot to that left subclavian. Okay, so we have this what's called likelihood ratios. These are when they look at research and statistics, they tell you what's the percent chance that this is an MI, or this is pancreatitis, for instance, or this is aortic aneurysm rupture. So these likelihood ratios, when they're more than one, that tells you, it equates to percentages, right? So if it's a likelihood ratio of 10, that's like a 45% chance that you have this disease processed. So you can see up here, if someone has, if they have similar to prior ischemia, same symptoms as before, that's about a 2.6, about what? About 15% likely they have an MI in your hands, right? And kind of make the picture add up. That's where you would do a 12 lead, you would do, troponins and such to see what's going on, all right, to see if they really have an MI or not. Okay, so they have history of peripheral artery disease. Well, that's a sign that they probably have an MI going on. They have abnormal stress test. We won't touch base too much on stress tests. That's usually outside the ICU. Usually we're beyond that. Usually if they did do a stress test, they definitely would have an MI. And you don't put someone on a treadmill that has ST changes. That's frowned upon. All right, and then pain rating to both arms is more common than pain just rating to one arm. Okay, so that's just something to note. It's like, oh, it's both arms, it can't be an MI. It's actually more common. Okay, so how do you know someone has ACS and not something that's like a pancreatitis or an ulcer or a what else? Abdominal aortic aneurysm. So these are different things. These three things right here usually tell you have someone with cardiac chest pain. Okay, so it's substernal. It's not subxiphoid. It's not what's the word? It's not epigastric. It is substernal, right? It's right below the sternum. It's pressure. It's not burning. It's not itching. It's not stabbing. It's not burning. I said burning. So it's not any of those things. It is pressure, right? And they'll describe it like an elephant on their chest. They might say it in 3 different languages. It's an elephant, right? I ask like an Arabic woman, what does it feel like? And then the daughter says, she says it's like an elephant on her chest. It's like, oh, see, it's not just an American thing. It's like people think elephant, and that's an elephant on their chest, and it's pressure. It's right there underneath the sternum. That is something that is classic for cardiac chest pain or for MI chest pain. Right? It radiates, right? It's radiating in both arms. That's much worse than one arm, but that's a sign that you have someone that has a cardiac chest pain. Okay, and then the pressure, again, elephant on the chest, and you start getting SNS symptoms because pain is a trigger for the SNS, right? So they start getting diaphoretic, they start getting a feeling of impending doom, they start getting, their pupils are dilated, but they also have a heart rate that might be going up, they might be breathing faster, so the SNS is firing off, right? Telling them that something's wrong, you got to seek out help, right? It's one of our internal signals to tell us something is not okay. So stable angina is brought on, of course, by exertion, right? I mean, does unstable angina, the only difference is, did it happen at rest or not, right? So walking, chest pain. Unstable being unprovoked, sudden onset. And then relieved by rest or sublingual nitro, that tells you have stable angina, right? If I give nitro and the burning epigastric pain doesn't go away, nitro is not going to help that. Protonics might, right? So you got to figure out which one it might be. And people that have really bad anxiety, that can lead to chest pain as well, right? And nitro is not going to fix that. So nitro does work on patients that have chest pain. Okay, should mitigate it some. It might not bring it down all the way to 0, but it might go to 10, to 7, to 3, or it might just stay around at a 5. So having those nitro is a good way to figure out if someone is, has cardiac chest pain or not. So beta blockers are contraindicated in like a CHF exacerbation, I should specify, because when someone has like an MI, we look to see, hey, is the blood pressure low? Well, maybe giving a beta blocker might reduce myocardial workload. All right, but if they have signs of like hypotension as well, beta blocker would not be given, just to specify that. So beta blockers are given in ACS and such, but as soon as you see that they have a history of CHF, probably not a good idea, or you see they have hypotension, that's also not a good idea. That's going to make things work even less than they should. Okay, calcium blockers definitely are not given in CHF. That is not a good idea, right? And how do you know someone has CHF exacerbation? That's usually when they have fluid in their lungs, right? Or they have pulmonary edema. They have they have cool extremities because the SNS is clamping down because they are in distress. That's not the best time to give beta blockers. Okay, but yeah, acutely, like acute MI, and they have symptoms of chest pain, and they realize there's an MI in our hands, beta blockers usually are indicated, but we have to be aware of the contraindications. Okay. Other symptoms that tell you might be cardiac chest pain, they got a new S4, right? So S4 is you go S1, S2 are normal, S3, S4 are abnormal. So what is S1, S2, what does that stand for?
Diastole and systole.
Yeah, so systole is S1, S2 is onset of diastole, but in the 1800s when they listed the chest, like S1, I'm gonna call that sound 1. S2, sound 2, right? S3, sound 3. S4, sound 4. And they realized that sound 3 and sound 4 are not accurate, or not a normal sound. And there's some physiologic reasons like in pregnancy and kids. But in MIs, sound 4 is not a sign that is telling you that you have it's telling you that you probably might have an MI on your hands, because sound 4 only happens when you have pathology, usually when you're older, but also it's a sign that your papillary muscles might have ruptured or might have had lack of flow because of an MI. New mitral regurg, that happens because our papillary muscles don't get the blood supply they need, and we'll kind of touch base on those when we talk about MI complications. But what else you have? What other things might tell you have a really big MI in your hands with all these chest pain signs? Also, they have signs of acute CHF, right? CHF exacerbation. They have rails. They got they have an S3 as well. They have JVD happening in front of you. The X-ray looks horrible. They got all this fluid in their lungs, and they have what's called a poor output state, right? Because the heart is not pumping out cardiac output. They're in a poor output state. So you get poor flow to your tissues. Your skin is going to be cool, right? And also going to be cool because your body is starting to clamp down with the SNS to try to reroute blood back to the heart. Okay, so yeah, you get low GI perfusion. They'll get nausea and vomiting, start throwing up on you with this chest pain. That's a sign that the heart's not functioning well. It's not pumping blood forward. It's backing up into the neck with JVD, also into the liver and into the GI tract, causing some symptoms of not wanting to eat or nausea and vomiting. Okay, and of course they get that dyspnea. They get rails going up to the apices. We'll do an X-ray to make sure A, that it's not an aneurysm, but also B, we can see on X-ray they got crackles developing, not crackles, but they have pulmonary vascular congestion developing on the X-ray. Okay, what tells you that it's not ACS? How do you know that this is definitely not an MI? If it is not substernal, like we mentioned, that's probably not it. If it is pleuritic, right? What does pleuritic mean?
Maybe it gets worse.
It hurts when I breathe, right? So how can you tell if someone has pleuritic pain or not?
See if it gets worse.
Or hold your breath. Does the pain go away? It went away. All right, and they start breathing, it came back. All right, that's probably, it doesn't go away with holding your breath, basically, right? Or does it get worse when they take a deep breath? So this pain is right there. It's at the muscle of the heart, and it's spilling out all this inflammatory stuff and lactate. That's not going to be affected by your breathing patterns, right? This is it's non-pleuritic, and it's non-positional. So if this chest pain goes away with my position, that is not an MI. It's impossible for it to be an MI. But it could be something else, right? That's something else that does cause ST changes, and what is that? Pericarditis, very good. So that's chest pain that goes away with what? Leaning forward, right? So leaning forward. So I lean supine, my inflamed pericardium is now with my lungs are pushing against my the back, my retroperitoneum, and that's going to then lead to that burning pain. Okay, and reproducible by palpation. Does it hurt when I touch? Does it hurt here? All right, yeah, when you touch, it hurts. That's not an MI, right? You can't touch someone's heart. Well, you can. That's why people get married. But anyways, you have if you palpate and it hurts, that's not it, right? That's not an MI. All right, so again, acute coronary syndrome has 3 different levels: unstable / rule out ACS. You'll see patients admitted with, and there's kind of debate whether that really should be a diagnosis or not. But basically, it's someone who doesn't have ST changes, but they still have the classic picture of chest pain. They might have a history of MI, might have a history of CAD, but they're being admitted because the troponin might be a little bit positive, but definitely there's no EKG changes, right? So troponin in unstable angina right here might be negative, might be positive, but it's not convincing. This is a patient that might get a stress test and be admitted to tele, okay? And then EKG changes, usually, worst case scenario, it's a STEMI, right? We have ST segment elevation, right? So ST segment elevation, that's a sign that we have a STEMI on our hands. And that's, we learn in ACLS that you have to, there's a whole algorithm we have to follow to make sure we're doing all the things and getting these patients reperfused as quickly as possible, right? And then we have, if it's not ST elevation, it might be ST depression, right? So we got this ST segment is depressed, right? And it's called STD. So in this case, you do want an STD. This is something where you definitely want an ST elevation because that is going to, you know, that means your heart is really not getting the blood supply you need. And ST depression might mean that you still have perfusion to your myocardium, or there's still perfusion occurring. But ironically, these patients die more than ST elevation MIs because STEMIs, we got a protocolization, go to the cath lab, 60 minutes or less. It's really 90 minutes, but our goal is 60. But we get them in there right away, and you get them fixed right away. Whereas an STEMI is like, oh, you're fine. We'll get you cath lab in the morning. Oh, it's Sunday. Let's try again tomorrow. We got a lot of cases. So then sometimes it gets pushed and pushed and pushed. This patient gets worse and worse and worse. So that's why it's important to monitor these patients to make sure they're not getting worse. Okay, like you patients all of a sudden being put on BiPAP. It's like, why is this patient being put on BiPAP? Right, it's because they have this MI that's developing underneath, that's causing that fluid to build up in the lungs. So we have to pay attention to these patients just as much as a STEMI. Okay, so classic chest pain starts in the chest and it radiates, right? Might radiate to the jaw, left arm, both arms. So that is, and it's substernal, non-positional, non-pleuritic, right? And doesn't hurt when I touch it. Okay. So non-ischemic chest pain. So these are the other reasons why you might have chest pain. So we want to figure out, is it something cardiac? Is it something GI? Is it something worst case scenario? When someone comes with chest pain, the worst case scenario is a aortic dissection. That is something that you really can't fix. Has like a 50% mortality if it happens outside the hospital, and once they make it to the hospital, it has another 50% mortality. So it's a really, really serious situation you don't want to miss. Someone has chest pain, they're not to describe it as positional, obviously. They're not going to describe it as pressure. They're going to describe it as tearing. They can literally feel their aorta ripping in half, right? So that is a aortic dissection. So someone says, oh, it's a tearing sensation. That should be red flags, bells going off, because that is a problem. All right, that is the worst case scenario. And yes, you can have aortic dissections in the abdomen, and they obviously would not have chest pain if you have an aortic dissection, but they're still going to describe it as a tearing sensation, and it radiates to the back, right? So chest pain that's radiating, or that's tearing and radiating from the chest all the way to the back, that's a sign of aortic dissection. Okay, and then when it dissects, it's dissecting across the three arteries at the top of our aortic arch here, right? We got our right brachiocephalic, we got our internal carotid, we got our subclavian, and so all these guys are you're going to get a change in blood pressures. If you imagine you take a blood pressure on this arm versus this arm, right? If they are different by, was it 20%, right? Or greater than 20 point difference between both arms, that is a sign you have an aortic dissection. It's almost 83% accurate. Remember the previous slide, the best we can get for MIs is like 20-30%, right? As far as, oh yeah, that's for sure an MI. Whereas if you have this difference, because it's literally tearing across here, right? That means this arm is going to get less flow compared to the other arm. And yes, you can have a dissection that goes all the way up to the aortic valve. That's not great, right? So that's type A, a dissection. Type A is where you awaken the surgeon in the middle of the night. That's a really bad aortic dissection. Okay, and how do you know someone has a aortic dissection? Yeah, you can do like a CT scan, but one of the things we do to make sure no one gets missed, right, when someone has chest pain, is we do a X-ray, right? So this X-ray happens to make sure no one gets missed, because this guy right here, John Ritter, he was popular in the 80s and 90s. So he was filming a sitcom, and then he said, "I got chest pain." So oh, we got a hospital right across the street. Just walk right over there. So probably should have to walk him, but he went across the street, and he was sitting there in the ER, and then he died. So they figured out, well, why did that happen? It's like he had chest pain. It's like it could have been an MI, but they realized that on autopsy it was a huge aortic dissection, and we know aortic dissections cause this widening of the mediastinum. It gets widened. So everybody comes in with chest pain, gets a chest X-ray because of this. Right? It's called a Ritter protocol, to make sure that everybody gets this done, to make sure it's not the worst case scenario. It's not a aortic dissection. All right, because he probably didn't have EKG changes. He probably threw in the EKG. It's like, well, you're fine. All right, there's no ST changes. What are you talking about? All right, we'll just monitor this. We'll give you some morphine. All right, and as we'll find out, morphine is not good for chest pain. Then we'll give you this and that, and we'll see if you get some oxygen. And look, nitrates didn't really help, did it? So then they realized that this is a dissection that they had. Okay. Also, what puts your risk for aortic dissection? They have cocaine use. They have history of hypertension, right? They were in the gym, right? We've had this happen where patients are in the gym and they develop a dissection, right? They just fall over and they have dissection there. All right. Males are 2 times more likely than females for developing dissections. And then pericarditis. So like we mentioned this, you got a pleuritic chest pain because that inflamed pericardium is irritating the pleura that's right next to, and those pleura are now compressed on top of the pericardium. That's going to cause even more pain. And when are the pleura compressed in the pericardium? When you are laying flat, right? And when you lean forward, you get the pleura off the pericardium, and therefore you're going to have less pain, right? It just sounds like leather rubbing against itself. It's really hard to appreciate. It's called a friction rub. Right, and sometimes you can have pleurisy, which is like an upper respiratory infection that causes pleuritic this rub sensation. So again, hold your breath, and if I hear the heart beating with that friction rub, that's pericarditis. Okay, and pericarditis can lead to effusions that develop around the heart, and that can then build up and build up and build up and cause tamponade symptoms. Right, so tamponade symptoms are worrisome with someone that has a pericardial effusion or pericarditis. So those are symptoms of low blood pressure because it's squeezing the heart. It's being tamponaded. It can't expand like it should. And since it can't expand, it can't fill with blood. So all the blood starts backing up in the right atrium side, backing up into the jugular veins. So you get jugular veins distension and you get low blood pressure. If you tell me you hear muffled heart sounds, I'm not going to believe you. Right? This is almost impossible to appreciate unless you have like an echo stethoscope. You can say, look at the decibel, it changed, right? But you know what? If they have like a young patient in the 30s, maybe. Like you can say, oh, I said them yesterday, there were loud heart sounds, and now they're definitely muffled. But it's really hard to appreciate that. But when you have the other symptoms of your blood pressure dropping and you got the JVD occurring, that's kind of leading us more towards a pericarditis complication of tamponade. And then lungs. So lungs can cause chest pain. So you got a pulmonary embolus that causes chest pain. Sometimes they might have like little hemoptysis with it, but usually you're going to see this sudden onset. And yes, MIs can be sudden onset too, but is pulmonary embolus going to get better with nitro? No. And will they have troponin elevations when we start doing lab draws? Yeah, because you blocked part of the flow to the what side of the heart? One side of the heart is pumping blood, and all of a sudden, bam, there's a clot in the way. What side of the heart is that? Not the left, the right. All right, the right side of the heart pumps blood to the lungs, right? And if you have a pulmonary embolus on that right side, that's going to, you put extra strain on the right ventricle, right? The right ventricle is going to get these strain patterns, which you can see on EKG as well. All right, so it has and this could put that strain. You can see the troponin being positive, and there's other symptoms you can look on echo to see that they have a PE or RV strain on your hands. All right, so who's at risk? Someone who's immobile, they got a DVT, so you see a huge swollen leg that's red on one side, not both sides, but one side, and all of a sudden they have sudden shortness of breath, or they're like a post-op patient that wasn't on Lovenox for 3 to 7 days, that could be pushing us high risk for a PE. So the clinical symptoms, but also the clinical picture, what their background is, to clue you into what kind of chest pain you have in front of you. A pneumothorax causes pain. So it causes chest pains. That's also sudden onset. So how do I know that it's a PE versus a pneumothorax for a patient on the ventilator, let's say? How would you tell? Yeah, absent breath sounds, but also on the ventilator, what would you be able to look at? Yeah, you have high pressures, right? The plaques would be elevated. That's how your pressures are elevated, because will that happen with a PE or the pulmonary embolism? No, right? Because the pulmonary embolism is not interrupting respiratory physiology. It's only, well, technically, yes, it's reducing it's increasing your VQ, but at the same time, it's going to be, you have this sudden chest pain on your ventilator, shows that you have a rise, your pressure starts going off. That's a sign that you might have a pneumothorax in your hands. Also, by history, you're on PEEPs of 14, tidal volumes of 500, and you asked all day to get the tidal volumes lower, and all of a sudden now you have these symptoms, these sudden symptoms. Okay, yeah, absent breath sounds, no adventitious lung sounds. So adventitious means what? No, that sounds advantageous, but adventitious means that it's abnormal, right? So you have clear lungs, basically. You have clear lungs on one side, and the other side is reduced, right, or absent, I should say. So ipsilateral means the same side. That's like a neuro term, but the same side of the pneumothorax has absent lung sounds, right? And the other side has no bad lung sounds, right? But in the ICU, we have patients that have CHF and get ventilator-assisted lung injury, right? And so it's just like a perfect textbook kind of picture. But yes, you do have patients with COPD and huge pneumonia bilaterally that do also get pneumothoraces. Okay, so again, history. They're a smoker, COPD patients get spontaneous pneumothoraces all the time. That's kind of really clue you in that it might be a pneumothorax versus someone that's obese with a swollen leg that's red and has been hurting for a week, right? And just had hip surgery and hasn't been on Lovenox for 7 days. It's like, which one is the one that has the pneumothorax? Probably the one that's this post-op, right? So recent chest procedures, right? We usually, when we do a chest procedure, we get an x-ray afterwards to make sure they don't get a pneumothorax. What kind of procedure might that be? A chest tube placed, right? You need a chest tube to fix the pneumothorax. So hopefully when you put the chest tube in, you don't get a pneumothorax. So we want to see that we have no pneumothorax on our hands post-procedure. What procedure might that be? Thoracentesis, yeah, that's a good one. But usually what commonly we do in the ICU is a central line placement, right? A subclavian or jugular central lines need an x-ray afterwards to make sure we didn't deflate a lung. Okay, so that's the idea behind you getting that x-ray afterwards. For femoral line placement, do you need an x-ray? No, it's not that long. It's only 20 centimeters, right? From the groin up, it's not going to reach the lungs. It's not possible. All right, and pneumonia can cause chest pain because they've been coughing for 3 weeks. They have all this sputum production, and it's definitely after they've resolved the pneumonia or later in the pneumonia course, they could get this pleuritis that develops this inflammation of the lungs themselves. And also, they're going to have a fever and sputum. Someone has a pneumothorax can have a fever? No. That's if someone has a pulmonary embolism, can they get a fever? Not really. Yeah, maybe in some fringe cases, but it's not as common as someone has fever and sputum. Right, that's not going to be, you're leaning more towards a pneumonia situation. All right, other reasons for chest pain, you might have an aortic valve stenosis. That's the exit to the heart, right? That's the aortic valve that, if that doesn't open, it's stenotic and scarred and calcified. It's not able to open. You're going to get a lack of blood flow to the rest of your body, right? Including your coronary arteries. So right outside your aortic valve right there is where you perfuse your coronaries. So we want to make sure that we are, if we aren't getting blood flow out of our heart, we can then get chest pain because of that, a poor cardiac output. Okay, and then vasospasm, that's a more uncommon reason for angina. It can definitely happen with patients that take cocaine. That can put them at risk. Musculoskeletal reasons, they have costochondritis, they slept weird, right? That could be cause muscle spasm, cause chest pain. GI-wise, they might have some GERD, right? Gastroesophageal reflux disease, peptic ulcer disease. We'll kind of touch base on these when we talk about GI. But those guys will be like epigastric pain or right upper quadrant pain if it's like a gallbladder situation, or left upper quadrant pain if it's like a pancreatitis situation. And then psych reasons. They can have chest pain because they're getting a panic attack. That could be a reason for chest pain. So again, clues, it's not ACS, right? It's pleuritic, it's sharp, it's burning, it's tearing. That's the quality of the pain. That's not chest pain. That's coming from an MI. What does the chest pain that comes from an MI feel like, or sound like, or reported as? It's reported as an elephant on the chest. It's the pressure, right? And then what is not ACS, the duration. Again, this is the PQRST. When you ever assess pain, you assess the pain, of course, what level it is, what's the quality, how long, when did it start? If it started right away, yeah, that could be an MI, but it's going to be, sometimes with angina, they're working out in the yard and they get this chest pain that doesn't go away. Okay, so random onset, last seconds, and it goes away. That's probably not chest pain, right? But it's something to get you investigated. But it's it's lasting for hours or days. Well, we have some patients that last hours or days, and they finally go to the ER, right, out of the request of their wife, and they say, okay, he's been having this chest pain since Saturday, and it's like it's Friday. So then might be a reason that it can happen. Onset after a meal. Right, digestion does not put extra stress on the heart. That's not something that's probably going to be like a peptic ulcer disease or gastric reflux, or even like gallbladder attack. And posture change. So that's in green here. That's our pericarditis, right? So it's somewhat color coded. And then location. If it's just in one spot and it's not radiating, it's probably not an MI. And yeah, there are some MIs that are like that, but it's, again, we're going to do some more workup to see what is going on. And then just a point that, women can be elusive sometimes. They can have symptoms that are more, what's the word, occult. All right, occult meaning not magical, but it means that they have they have symptoms that are not classic, like an MI, like a regular MI might present. Like men need clear signals; they know exactly what's going on, right? Because they are not exactly, they have to say, oh, I'm cold, I'm feeling cold right now. It's cold outside. Well, you didn't ask for a jacket. You should have asked me for a jacket, right? So men need clear instructions. So you have chest pain that's radiating to the left arm or your jaw. That is MI chest pain, whereas a woman might have just symptoms of like pain in the back, or that's, it's radiated, or they might have just shortness of breath, for instance. And diabetics and females, that puts you more at risk, because diabetics have we talked about the crystallization of their vessels, making hypertension happen, putting at risk for an MI, but also have the crystallization of the nerve fibers. So you get neuropathies, and they don't have the feeling of pain, of this classic pain that's radiating. So your diabetic patient can have symptoms of just shortness of breath, for instance, or just maybe diaphoresis. So we have to, consider that as well. And of course, the 12 lead is not going to lie, and the echo might not lie, or the cath lab won't lie. So we have to still have suspicion for these things. Okay. And of course, we mentioned it doesn't respond to nitrates, rest, or position. That's something that is not ACS. All right. When we give nitrates to someone with ACS, their chest pain should usually get relieved a little bit, or altogether. Okay. So you're asking for chest pain. You want the pain level, you want the quality, what it feels like, right? And sometimes your patients don't give you the most clear answers.
Hey, sir, I hear you having some chest pain. Why don't you tell me what's going on?
When I was a young boy, my father took me into the city to see a marching band.
That story sounds amazing, and I really would love to hear the end of it. But if you could just dial it back to today, and specifically why you called 911 now.